known 826 study, which showed that pembrolizumab plus chemotherapy versus placebo plus chemotherapy for persistent, recurrent, or metastatic cervical cancer. This was a randomized phase 3 study which was conducted in over 19 countries in over 151 centers by Bradley J. Monk. The treatment landscape of cervical cancer is ever evolving, whereas while in 2004, the GOG-204 study established taxane plus platinum as the standard of care for metastatic cervical cancer. Following in 2014, the GOG-240 study showed the addition of bevacizumab is associated with a median overall survival of 17.5 months. Today, in October 2021, the FDA granted accelerated approval to the addition of pembrolizumab with chemotherapy with or without bevacizumab based on the interim analysis report of less than 2 years. The interim analysis showed clinically meaningful overall survival and progression-free survival improvements and was generally well tolerated in patients with persistent, recurrent, or metastatic cervical cancer. This is a protocol-specified final overall results with a duration of more than 3 years. The eligibility criteria for the participants were they should have persistent, recurrent, or metastatic cervical cancer not suitable for curative treatment with no prior systemic chemotherapy. However, prior radiation and chemoradiation was permitted. The radiation should have been completed at least 2 weeks prior with a washout period of 1 week at least. With a performance status of 0 or 1, the stratification was based on whether the population had metastatic disease at diagnosis or not. PD-L1 CPS scoring less than 1, 1 to 10, and more than 10, and planned bevacizumab use, which was up to the discretion of the investigator. They were randomized in a 1-to-1 ratio to the trial arm, which was pembrolizumab 200 milligram given 3 weekly for up to 35 cycles with a taxane and platinum, either cisplatin or carboplatin, 3 weekly for up to 6 cycles with or without bevacizumab, and in the with a matching placebo, the same chemotherapy and the bevacizumab regimen. There were dual primary endpoints: overall survival and progression-free survival, assessed according to the RECIST criteria. The secondary endpoints were overall response rate, the duration of response, and the safety profile. At the first interim analysis of the study, up to a duration of 22 months, less than 2 years, the progression-free survival was 10.4 months in the trial arm versus 8.2 months in the placebo arm, which was statistically significant with a hazard ratio of 0.62. This was done in a population with a CPS score of more than or equal to 1. The overall survival, however, was not, the median overall survival, however, was not reached with a hazard ratio of 0.64. In the all-comer population, that is the population including all those with, irrespective of their CPS scores, the trial arm showed a median progression-free survival of 10.4 months versus 8.2 months, and the interim overall survival 24.4 months. The confidence interval, however, was not reached, and the trial arm 16.5 months. So, coming to the statistical consideration, the protocol-specified analysis was timed when 378 events of death should have occurred in the CPS in the population with CPS score more than 1. And the success criteria, given that the success criteria for the study hypothesis were all met at the first interim analysis, no formal hypothesis testing was performed for this final analysis, and all p-values were nominal. And the cutoff date was October 3, 2022. All randomized participants were analyzed, and safety was also assessed in all participants who had received at least more than 1 dose. So, 617 participants were randomly allocated to both arms, with more than in the trial arm, more than 5.9% continued with all the with at least receiving at least one component. 21.2% completed all components. Whereas in the trial arm, only 8.7% could complete all components. The baseline characteristics of the study population were all histologies were included in the study, although squamous cell carcinoma was a predominant histology. And coming to the PD-L1 scores, predominantly the study population included more than 51% belonging to CPS scores more than 10. And for the prior therapy, the majority received prior chemotherapy. 4B was the predominant stage of initial diagnosis, and metastatic disease inclusion was around 18%. Coming to the final overall survival results in the population with CPS scores more than one, it showed the trial arm showed 28.6 months versus 16.5 months with a hazard ratio of zero point 0.6. This is more than 1 year survival benefit. And the all-comer population, similar results with 26.4 months versus 16.8 months with a hazard ratio of 0.63. And in the CPS, more than 10 percentage, 29.6 versus 17.4 with a hazard ratio of 0.58. The One important point to note is that irrespective of whether the bevacizumab was used or not, it has showed a overall survival benefit. And however, the PDL score, those with PDL score less than 1%, an overall survival benefit could not be shown. But this is too early to comment because only 11% of the population had CPS scores less than 1. And CPS more than 1%, final progression-free survival results 10.5 months versus 8.2 months with a hazard ratio of 0.58. And in the all-comer population, similar results with 10.4 months versus 8.2 months with a hazard ratio of 0.61. In the CPS more than 10 population, 10.4 months versus 8.1 month with hazard ratio of 0.52. Similar results as in the overall survival results, irrespective of whether however, with progression-free survival, both groups, bevacizumab showed similar results. And as said earlier, PD-L1 score less than 1, they could not show a progression-free survival benefit. The overall response rate and duration of response was significant in all the populations, with 68.5% showing improvement in the overall response rates in the CPS more than 1, 66% in the all-comer population, and more than 10, 69.6 months. Coming to the safety profile of the results, almost both arms experience similar grade 3 similar toxicity results with, as expected, immune-related events were more in the immunotherapy arm. The most common adverse event was anemia, followed by hair loss. Grade 1 to 2 toxicity was the predominant grade of toxicity. It had manageable safety profile. And coming to the immune-related events, hypothyroidism was the most common immune-related event, with most in the grade 1 to 2 range. So coming to the takeaway message from the Keynote 826 study, with a median follow-up of 39 months, that is more than 3 years, the ratio of pembrolizumab to chemotherapy without bevacizumab continued to show substantial and clinically meaningful overall survival and progression-free survival improvements in women with persistent recurrent or metastatic cervical cancer. The benefit was observed in all protocol-specified primary analysis population, whether be the irrespective of their CPS scores. Benefit was generally consistent across all protocol-specified groups, including with and without bevacizumab subgroups. Overall response rate was also high and duration of response was longer with the addition of pembrolizumab, which showed an improvement in their quality of life over the years. The time to deterioration was significantly longer in the immunotherapy arm. The safety profile was manageable and observed adverse events was expected based on the profiles of the individual drugs. No new safety signals were flagged. Thank you.
Good morning, everyone. Thank you, Megha, for the presentation. Now, this drug pembrolizumab was first approved in 2014. Ever since its approval, it has been used in like around 16, 17 malignancies, of which cervical cancer is one now. Now, as far as we are concerned, most, or in fact, almost all of our patients belong to a middle or a lower socioeconomic class who present with your metastatic or recurrent CS cervix. We are talking about a drug that will be costing you around 2 lakh per month. So these are patients who can't even afford bevacizumab. So as far as they are concerned, this drug is a far-fetched dream. So what I would say is, in cervical cancer specifically, your local recurrence rates have come down very drastically with your newer image-guided radiation techniques and brachytherapy. Another option to bring down your cancer burden is the promotion of the more of the vaccines. So we have better cost-effective ways to reduce your cervical cancer burden. So instead of pumping money to the other end of the spectrum, it would have been better it was the other way around. Another thing is your immunotherapy has been found to be more effective in the post-radiation setting. So a comparative study between the effect of pembrolizumab in patients who have received surgery only versus those who have received radiation only would have been a good option. Hopefully, by 3-4 years, once the patency of this drug is over, the drug would become more affordable and to the general population. Thank you.
Next is our discussion on its Peace One trial. To present the topic, I invite Dr. Neeraj from medical oncology. And to chair the session, I invite Dr. Sridharan sir, senior consultant, medical oncology.
A very good morning to all of you. Today I will be presenting on the efficacy and safety of abiraterone acetate plus prednisolone and the standard of care, that is ADT plus docetaxel, in older patients more than 70 years with de novo metastatic castration sensitive prostate cancer compared to younger patients. This was a subset study of the Peace One trial. So the background of the study: metastatic castration sensitive prostate cancer, they have shown a rapidly evolving standard of care has occurred over the past 1 decade for the treatment of metastatic prostate cancer. Initially, in 2013, we had the option of ADT alone for this group of patients. But in 2015 came the introduction of docetaxel to the standard of care based on the trials of Chartered and Stampede trial. Then in 2017, there was the introduction of abiraterone acetate prednisolone based on the Stampede as well as the Latitude trial. Then there were trials which has evaluated the addition of radiotherapy to the primary to ADT. And then you have the newer hormonal therapy with apalutamide, enzalutamide, etc., based on the ENSAMID study, ARCHES trial, etc. So now we have a wide array of drugs which are used in the treatment of metastatic castration-sensitive prostate cancer. Coming to our study, that is Peace One. Peace One, it is actually a phase 3 randomized trial which was conducted between 2013 to 2018. It was conducted in 77 centers across 7 European countries, mainly French, Ireland, etc. So this study, it included metastatic castration-sensitive prostate cancer. They were primarily diagnosed as metastatic with a good performance status of 0 to 2. And they were stratified as a 1:1 randomization. It was a 2:2 factorial study. That is the 4 groups in total. The first group was a standard of care. The second group was standard of care plus abiraterone. The third group was standard of care plus radiotherapy, and the fourth group received standard of care plus abiraterone plus radiotherapy. So the patients were nearly randomized to all 3 groups in equal numbers. So the Peace One trial, the standard treatment was androgen deprivation therapy, which was either by LHRH agonist or antagonist, or surgical castration, bilateral orchidectomy. This was the original standard of care at the time of the start of the study in 2013. However, it was later amended in 2015 to include docetaxel also in the standard of care group. This was based on the new studies of Stampede and Chartered, which came into publication in 2015. The experimental treatment group received abiraterone 1000 mg per day plus prednisolone until disease progression or intolerance. Another group also received radiotherapy to the prostate. So the findings of this Peace One trial was that abiraterone plus prednisolone, when added to the standard of care of ADT plus docetaxel, it improved the overall survival nearly by 1.5 years and radiographic progression-free survival by 2.5 years. There was only a modest increase in toxicity. So this triplet regimen of abiraterone acetate prednisolone plus ADT plus docetaxel became a standard of care. This post hoc analysis, which was presented by Dr. Mark Louis in this ASTRO 2023, it investigated the safety and efficacy of abiraterone acetate plus prednisolone stratified by age in Peace One. That is, whether in older individuals more than 70 years, this triplet regimen of abiraterone acetate prednisolone ADT plus docetaxel, is it associated with more benefit than risk? So patient characteristic, about 741 patients were less than 70 years and 431 patients were more than 70 years. You can see that patients with a lower performance status were more common in the older age group. Patients with hypertension, diabetes mellitus, etc. were also more common in the elderly age group. And because of this fitness issues, docetaxel was given as a standard of care in only 51% of the patients more than 70 years. Coming to the result, efficacy was analyzed by the radiographic progression-free survival and the overall survival. You can see that this blue line represents the radiographic progression-free survival of patients with age less than 70 years, and this red line indicates the same in age more than 70 years. You can see that the radiographic progression-free survival as well as the overall survival tend to be lower in patients more than 70 years. The benefit of adding abiraterone acetate plus prednisolone, it tended to decrease with age. That is more than 70 years, it tended to decrease. This is applied to both the RPFS as well as the OS. The hazard ratio was 0.65 for older men, 0.49 for younger men. The same was observed in OS. But one interesting factor was that when those patients who were fit enough to take docetaxel as standard of care, that is patients who received abiraterone plus docetaxel plus the ADT. Those patients who are more than 70 years old. So in this group of patients, it was comparable. That is the standard of care which comprised of ADT plus docetaxel as well as abiraterone acetate plus prednisolone. In them, the RPFS benefit was comparable between both the older men as well as the younger men. This was the result of efficacy. Coming to safety, it was found that grade 3 to 4 adverse events were more frequent in older men, that is 69% versus 61% in younger men. Similarly, the median time to discontinuation, that is because of the side effect, the discontinuation of the drug was more common in elderly population, and the median time to discontinuation was shorter in the elderly population. So coming to the conclusion of the study, in the overall population, the older men derive a lower benefit both in terms of the radiographic progression-free survival and overall survival from adding abiraterone acetate plus prednisolone to standard of care versus younger men. That is, a triplet regimen of abiraterone acetate prednisolone plus ADT plus docetaxel may not be that feasible in the older age group of more than 70 years. This decreased benefit is likely due to more toxicity, leading to more frequent and earlier drug discontinuation. So the current recommendation is for careful evaluation based on geriatric assessment, comorbidities and polypharmacy, which should be done in elderly men more than 70 years of age before considering this triplet therapy.
Treatment of prostate cancer has become more complicated over the last 10 years. Previously, it was very easy. We only had AD. Now we know that dual drug therapy is the standard. You combine ADT with either abiraterone, docetaxel, or one of the new antiandrogens. How do you choose between these second agent? We don't have good data for that. It's basically physician and patient preference. Patients who are having cardiac failure, fluid overload problems, you tend to avoid abiraterone. Patients with seizures, you tend to avoid enzalutamide. Patients, young big patients with high volume disease, you try to give chemotherapy. So there's no clear data of how to choose the second one. But having said that, docetaxel has got some advantages. One is the duration of treatment with docetaxel is very short. You need 6 cycles of treatment and you are getting almost 13 months of survival, similar to abiraterone. So the cost of therapy is very low with docetaxel. The second point with docetaxel is that we know that docetaxel works better in castration sensitive prostate cancer rather than in castration resistant prostate cancer. So if you think that you can give an antiandrogen and when the patient fails, you can give docetaxel as second line, they somehow do not trust. And third and most important is a small percentage of people with prostate cancer, they progress very fast. They have they turn into high grade, rapidly metastasize, and have a very fatal course. This small percentage is what is bringing down the overall survival results for patients with second generation antiandrogens when combined with AD. So if you can give docetaxel upfront to all these people, maybe you can prevent this progression. So now we have data for triple therapy with ADT, docetaxel with an anti-androgen. We have data for all the drugs. Abritron, we have data with enzalutamide, we have data with darolutamide. So we can use any one of these three agents along with docetaxel and ADT and try to give. But again, what this subset analysis shows us is you have to choose your patients wisely. Young, fit patients, high volume metastatic disease, triplet therapy may be the combination of choice. Older patients may be doublet therapy. Our kind of patients who are economically and physically frail may be single agent ADT, maybe just orchidectomy alone. We should not forget that ADT is a good option even in this case. Thank you.
We're moving on to the next topic. Next is the SHAPE trial. To present the topic, I invite Dr. Geeta from Surgical Oncology. And to chair the session, I invite Sham sir, Head of the Department of Surgical Oncology.
Good morning. Today my topic is SHAPE trial, comparing radical hysterectomy and pelvic node dissection versus simple hysterectomy and pelvic node dissection for low risk early stage cervical cancer. So the background is that the cervical cancer is among the top causes of cancer-related deaths in the women worldwide. So radical surgery in women with cervical cancer is effective, but is associated with long-term survival issues such as effects on bladder, bowel, and sexual function, because we remove a lot of the parametrium that involves the autonomic nervous system, nervous supply to the bowel, bladder, and the sexual organs. So the retrospective data suggests that in patients with low risk early cervical cancer, less radical surgery is feasible and associated with less morbidity. And the CCTG SHAPE trial was undertaken to evaluate whether a simple hysterectomy is associated with similar efficacy and less morbidity versus a radical hysterectomy in patients with low risk cervical cancer. So it was an international randomized non-inferiority phase 3 trial. So the patients with low risk cervical cancer were defined as those having squamous cell adenocarcinoma or adenosquamous carcinoma, stage 1A2 or 1B1, less than 10 millimeters of stromal invasion on LEEP or cone, less than 50% stromal invasion on MRI, with a maximum dimension of less than or equal to 20 millimeters, and grade is 1 to 3 or not accessible. So we divide them into groups that underwent simple hysterectomy and a group of patients who underwent radical hysterectomy, with about 350 patients in each arm. And all the surgery included pelvic lymph node dissection with optional sentinel lymph node mapping. The primary endpoint was the pelvic recurrence rate at the end of 3 years, and secondary endpoints were pelvic recurrence free survival, extra pelvic recurrence free survival, overall survival, rates of sentinel lymph node dissection, parametrial involvement, involved surgical margins, positive pelvic nodes, and patient reported outcomes. So these were the baseline characteristics. The number of patients that were matched based on the low risk factors that we have seen before, and these are surgical treatment parameters. Surgery was either abdominal, laparoscopic, robotic, or vaginal, and people underwent sentinel lymph node biopsy also in a subset of patients. And the key post-surgical findings on pathology that were taken into account were the presence of residual cancer, LVSI, positive nodes, positive vaginal margins, positive parametrium, and lesions more than 2 centimeters. A number of people who underwent adjuvant treatment was also taken into account, which was 31 patients in the simple hysterectomy group and 29 in radical hysterectomy group. So the clinical outcomes after a median follow-up of 4.5 years are, so the difference in 3-year pelvic recurrence rate was only 0.35. With the 95% confidence interval upper limit was within less than 4% of the range to be considered non-inferior. And the subgroup analysis showed that showed the non-inferiority of the simple hysterectomy across the evaluated subgroups, as we can see in the table. And there were 7 deaths in each arm. And so the pelvic recurrence rate for simple hysterectomy was non-inferior to that after radical hysterectomy. So intraoperative complications that were evaluated were associated with bladder, ureter, nerve injury, bowel, and vein. And it was found that the bladder and ureteric injury were more with radical hysterectomy compared to simple hysterectomies. Acute and late surgical adverse events. So acute surgery related adverse events were defined as those occurring in patients within 4 weeks of surgery, and late surgery related adverse events were defined as those occurring after 4 weeks of surgery. And it was found that of all the adverse events, urinary incontinence and recurrence were more in patients with radical hysterectomy than in both acute and late than in patients undergoing simple hysterectomy. Relating to quality of life and sexual health. This was evaluated by the EORTC QLQ CX24 and the FSFI, that is Female Sexual Function Index pain scale, and it was found that patients who underwent a simple hysterectomy had higher scores on both the questionnaires and was found to have a better quality of life in terms of sexual vaginal functioning, sexual pain at months 3, 6, and 12 after surgery. Therefore, all of the patient reported outcomes favor a simple hysterectomy arm. So the conclusions were that among the patients with early stage low risk cervical cancer, simple hysterectomy was non-inferior to radical hysterectomy as assessed by the 3-year pelvic recurrence rates. That is 2.52 in the simple hysterectomy arm versus a 2.17 in a radical hysterectomy arm. And the simple hysterectomy was also associated with fewer urological complications, better quality of life, and better sexual health measures. So it was concluded that following an adequate and proper preoperative assessment, we can now consider simple hysterectomy as a new standard of care for patients with low risk early cervical cancer. Thank you.
Let's yet another practice changing study from this field of cervical cancer after the LAC trial. LAC trial made us to operate open surgeries, go for open surgeries in the cervical cancer. Now it comes as a simple hysterectomy would be okay for a early cancer, cervical cancer, rather than a radical surgery. Of course, when the radicality of the surgery, especially in the pelvic region, of course, the quality of the patient will improve in terms of bladder and sexual. And the data also shows that there is a quality of life. Thing is that one of the few worrying problems is that when it comes to simple hysterectomy, when we go for see the data, the vaginal hysterectomies are more in simple hysterectomy when compared to radical hysterectomy group. So don't know how it affect in the long term when you go for a vaginal hysterectomy in the case for a cervical cancer. Of course, for 3 year follow everything looks okay. That is pelvic recurrence, overall survival, disease-free survival, everything looks okay for a simple hysterectomy. But when you go for long term, especially the non-oncological people embark into this region, especially when a simple hysterectomy would be okay. So I think by looking at the abstract, I don't think we can just go into the practice. We'll have to wait for the long-term results. But of course, the other thing, quality of life, of course, it's understandable that when the radicality decreases, the quality improves, and especially in pelvic surgeries.
So you know the standard of care in stage 2 seminoma is either RT or it's chemotherapy. So the role of RPLN is not that much addressed in the case of stage 2 seminoma. So next we have a topic on primary RPLN in seminoma in stage 2A or 2B lesser or equal to 3 centimeter. To present the topic, I invite Dr. Lokesh from surgical oncology, and chair the session I invite Dr. Fazlur Rahman, consultant and surgical oncology.
Good morning to all. Today's my topic is primary retroperitoneal lymph node dissection in seminoma stage 2A and 2B. Myself, Dr. Lokesh, resident from SOG, and moderator is Dr. Faslu Raghuvan. So this is based on the trials of Svenateka and Quatrims. Svenateka is Sweden and Norway Testicular Cancer Association, and Quatrims is Cologan trial of retroperitoneal lymph node dissection in metastatic seminoma. So these two, based on these two trials, we are going to see whether the primary lymph node dissection in seminoma for stage 2A, 2B less than 3 centimeter. So before going to this one trials, first we will see the stages of seminoma. So stage 1 is no evidence of metastasis. 1 MK is tumor markers are positive without any evidence of metastasis. 2 is abdominal node involvement. 2A is less than 2 centimeter. B is 2 to 5 centimeter. C is more than 5 centimeter. 3 is supradiaphragmatic node involvement. 4 is other metastasis. So in our trial, in our study, we are going to see on 2A and 2B. So that is less than 3 centimeter only we are going to compare. So in testicular cancer, there is a long-term toxicity there. In the testicular cancer, it has a very high cure rate. For a clinical stage 1, 5-year overall survival is more than 98%. Whereas metastatic non-seminoma overall survival is more than 90%, and seminoma overall survival is more than 96%. The long-term life expectancy following treatment is 40 to 70 years. So it has a high overall survival rate. But after the treatment, there is a long complication rate. So the relative survival of the testicular cancer survival graph should be flat, because most of the complications after the adjuvant treatment of seminoma, chemotherapy or radiotherapy affect after more than 20 years of the follow-up. So so here the more complications occurs when you are giving more than 4 cycles. Then the next line shows if it are giving 4 cycles, there are more complication rates on follow-up. So our aim is to to study about the long-term toxicity of the this adjuvant therapy. So why primary ALPLD? There is no increased risk rate of late toxicity affecting the mortality. So many small serious and new trials, STEM trial, surgery in early metastatic seminoma, prime test. These are some small trials which proves that retroperitoneal lymph node dissection in case of seminoma 2A and 2B less than 3 centimeters very effective, and it has very less complications when compared to our standard treatment of chemotherapy and or radiotherapy. So RPL&D, how will it do? So preoperatively will do FDG PET. If there is upstaging in the tumor, you will treat according to the risk group. If the preoperatively the FDG PET is positive, will do primary unilateral RPL&D. If it is negative, then we'll do tumor marker. The tumor marker is positive, then we'll do primary unilateral RPL&D. If it is tumor marker negative, then we have to go for histology. If it is seminoma, we'll do primary RPL&D. Others will keep surveillance. So in primary, after doing primary LPND, we have to look for whether it is less than 2 lymph node and size less than 3 centimeter, then we just follow up. Or if it is more than 2 lymph node or size more than 3 centimeter, or if it is positive margin is there, we have to give adjuvant chemotherapy, BEP regime for 1 cycle. Or if the tumor marker is positive after RPLND, we have to give 3 cycles of BEP. This is the treatment regime they followed in this trial. And the results of the Svenateka and Quatrims trial, it's a 5-center trial. 94 patients were included, 66 from Svenateka and 28 from Cologne, and of this 58 from the clinical stage 1 and 36 from the stage 2A and B. So the median age of at RPLND is 41.8 years. The median follow-up is 21 months. And of this, 26 patients were robotic, and there are very less complications rate. 10 patients with clavin window of more than 2, and of this only 2 patients requires intervention, and 23 patients receive adjuvant chemotherapy. And these are the 59 patients we have been enrolled for more than 6 months for follow-up. Of this, relapse has been developed in 5 patients. Of 5 patients, of this 4 in the surveillance group and 1 patient with the adjuvant chemotherapy. So we'll see, these are the 5 patients who develop relapse after the RPLND, and the maximum time of relapse is within 8 months. And most of the patients, they didn't receive any adjuvant therapy after surgery. Only one patient has developed adjuvant therapy, and after the relapse, the most of them treated with the adjuvant chemotherapy BEP 3 cycles. So the conclusion of this primary RPLND performed by experienced centers is a promising new standard treatment option in seminoma. So it's a promising new option, but it's still the long term is not proven. The risk of late morbidity and the mortality is minimal when compared to the standard radiation or chemotherapy.
Thank you, Lokesh. Good morning, all. As we know, the standard of care in stage 2 seminoma is either radiotherapy or chemotherapy. So the backbone is always been the platinum-based chemotherapy, and the survival was excellent. For 5-year survival, approximately 96%. So now the focus has shifted to the late morbidities or late sequelae of this modality of treatments. So they found to have more of cardiac events, more of hypogonadism, cardiac, neuro or ototoxicity, or most important, second primary malignancies. So they are now they are trying other options that can de-escalate these treatment options. That include some de-escalating the chemotherapy regimens like semitic, or they can combine RT with chemo, that is 1 dose of carboplatin plus involved field RT. Similarly, the other option was being primary retroperitoneal lymph node dissection. So for this, they have got evidence from 2 trials, SEMS and PRIME. This one was done in US and Canada, and found they have around 80% of recurrent-free survival of 3-year follow-up. So they adopted this strategy into this Svenotica. So this is basically a series of patients they started treated since 2018. So this on these findings, the recurrence, this one, previous one. So there was 23 of them later received adjuvant chemotherapy based on the risk factors, like more than 2 nodes or more than 3 centimeters of lymph node metastasis or extranodal extension, of which they found to have 5 relapses, of which all of them were salvaged with the further chemotherapies. So, in conclusion, if you are looking at primary RPLND is more or like same as that of radiotherapy, and we'll have to salvage according to the recurrence or according to the risk stratifications. So now it's more of a investigative procedure, but in Sweden and Norway they are following this protocol. We'll have to wait for the long-term results, especially the overall survival data. Nothing is available. Only this series of patients are there. Only the median follow-up was only 21 months.
No. Yes.
Template RPLND. This template RPLND, because it was node was positive, so they did a unilateral template RPLND.
Progression from castration sensitive prostate cancer to the CRPC is largely unclear. So we know in prostate cancer the use of lutetium therapy, and in case of CRPC the role of olaparib. So we have a trial on the UPAR. There is a phase 1 trial of PSMA lutetium therapy with olaparib in metastatic CRPC. This is the topic I invite Dr. Vishnu from medical oncology, and to chair the session I invite Dr. Tansir, consultant nuclear medicine.
Good morning, everyone. I'm here to present the LoopUp study. It's a phase 1 trial of lutetium PSMA therapy plus olaparib in patients with metastatic castration-resistant prostate cancer. The background of the study is that lutetium PSMA is an efficient therapy in metastatic CRPC, which improves PFS and OS in these patients. And although many patients will derive benefit, 1/3 of patients will have primary resistance, and these patients will have median PFS of around 5.1 months, and all patients will eventually relapse. And lutetium PSMA therapy delivers beta radiation to the PSMA expressing tumors, which induces a single-stranded DNA breaks. And PARP, which repairs a single-stranded DNA repair, done single-stranded DNA breaks. And inhibition of PARP will will convert the single-stranded DNA breaks into lethal double-stranded DNA breaks, which is postulated to increase the radiosensitization of lutetium PSMA therapy and improve the efficiency of the therapy. So the hypothesis of the study is that olaparib will promote the radiosensitization of lutetium PSMA, resulting in intensification of DNA damage and improved efficacy. The primary objective of the study is that to establish the maximum tolerated dose, the dose-limiting toxicities, and recommended phase 2 dose of olaparib in combination with lutetium PSMA. Secondary objectives being safety and rate of treatment discontinuation due to toxicity, and anti-tumor activity as measured by radiological PFS, PSMA PSF, overall response rate, overall survival, PSMA response rate. So the inclusion criteria were patients above 18 years of age with ECOG performance status of 0 and 1 with metastatic CRPC, and who have progressed on ARP and docetaxel. The disease progression documented as per RECIST 1.1 criteria, and PSMA SUV of more than 15 at any one site and more than 10 at sites more than 10 millimeters with no FTG discordance, that is FTG positive and PSMA negative, with adequate organ function and no prior exposure to lutetium PSMA, cabazitaxel, platinum, PARP inhibitors, mitoxantrone, or cyclophosphamide. And they should be suitable for mandatory paired tumor biopsies for biomarker studies. So 48 patients who satisfied inclusion criteria were included, and they were put on olaparib on serial dose escalations ranging from 50 mg BD to 300 mg BD, along with lutetium PSMA 7.4 gigabecquerel 6 weekly, up to 6 cycles in conjunction with the olaparib. The toxicities considered were grade 4 neutropenia lasting for more than 7 days, and grade 4 febrile neutropenia, anemia, thrombocytopenia, or pneumonitis, and grade 3 or more non-hematological adverse effects, except nausea, vomiting, diarrhea, fatigue, tumor flare, and rash, which is not responding to the standard management. So the treatment schedule was olaparib ranging from 50 mg BD to 300 mg BD, along with lutetium PSMA 6 weekly up to 6 cycles, with PSMA PET being done at baseline and 12 weekly for 48 weeks. FDG PET done at baseline, bone scan at baseline and 12 weekly, and with circulating tumor cells and circulating tumor DNA done serially 12 weekly and at disease progression. And tumor biopsies being done at baseline and week 2 to 4 and at disease progression. Coming to the patient characteristics, median age was around 71, and around 66% of patients had received enzalutamide or abiraterone or other ARPAs, and around 22% patients received both enzalutamide and abiraterone, and around 12% patients received enzalutamide and abiraterone and other ARPA, and around 97% of patients had received docetaxel. 56% of patients were ECOG PS0 and 44% PS1. Median PSA was around 50, and Gleason score less than or equal to 7, 31%, and more than or equal to 8 and 62%. It was unknown in 6%. And there was measurable disease in 38%, whereas it was unmeasurable in 62%. Coming to the treatment-related adverse effects, there were no significant adverse effects noted. No dose-limiting toxicities were seen. No grade 4 adverse effects. And dose reductions were required due to treatment-related adverse effects in few cohorts only. Coming to the PSA response, 66% of patients had more than 50% response in PSA, and 44% had more than 90% response, and 78% of patients had an overall response rate as per RECIST 1.15. And coming to the PSMA expression, around 88% of patients had a detectable circulating tumor cells, and 65% patients had PSMA positive circulating tumor cells detectable. And around 47 patients had cleared total circulating tumor cells to 0, and 80% had a decrease in the total count. Around 87 patients cleared PSMA positive circulating tumor cells to 0, and 7% had an increase in PSMA positive circulating tumor cells. So to conclude, lutetium PSMA therapy in combination with olaparib had a promising activity, no significant dose-limiting toxicities, is well tolerated, and the recommended phase 2 dose of 7.5 gigabecquerel of lutetium PSMA along with olaparib 300 mg BD was found to be the recommended phase 2 dose. It was found to be a well tolerated combination.
So this trial was used two agents, that is lutetium 177 PSMA radioligand therapy. Its mechanism is it causes break in the single strand break in the DNA, usually repaired by PAR-mediated base excision repair. So giving the PARP inhibitor, we can increase the radiosensitization of the lutetium PSMA radioligand therapy. So it can helpful for increasing the improving the overall survival and progression-free survival. So in this study, we all know in vision trial and all, lutetium has given promising, lutetium PSMA has given the promising result in improving the overall survival. So overall in this study, so they are saying that PSA value of they found to reduce the PSA of 50% in 66% of the patient, and there is no dose limiting toxicity, and there is no grade 4 adverse effect in this phase 1 trial. And other things, overall response rate is around 78%. But even though the phase is very promising, but need more comparative study for further assessment.
So they have not mentioned.
They didn't mention about this.
Progress. Yes. Happen.
Unknown patient because they have given olaparib for only 2 weeks in 6 weeks.
Because one cycle consists of 42 days.
And they have given for only 2 weeks.
Yeah, this is given for 2 weeks.
2 weeks.
They would have given for all 6 weeks. BRCA unknown. They are giving purely to increase the effect of the lutetium. They are given for only 2 weeks.
Yes, yes. Yes, sir. So in this study, they kept the dose of lutetium PSMA as 200 milligram for all patients, and they have escalated the dose of olaparib. And recommended phase 2 dose of olaparib is 300 mg and lutetium PSMA is 200 milligram. But cost lutetium is lower.
We are moving on to next topic. That is the role of cytoreductive nephrectomy in metastatic RCCs remains unquestionable based on the Satem and Carmina trials. So that is the sunitinib era. So we have a role of cytoreductive nephrectomy in metastatic RCC in the era of immunotherapy. To present the topic, I invite Dr. Vishnu KS from Surgical Oncology, and to chair the session, I invite Dr. Deepak Damodaran, Senior Consultant, Surgical Oncology.
Good morning, all. So my topic is on the role of cytoreductive nephrectomy in metastatic renal cell carcinoma in this era of immunotherapy. This is an analysis of the national cancer center database. So when you look at the history of cytoreductive nephrectomy, initially in a metastatic renal cell carcinoma, we used to do give interferon, that is interleukin 2 or interferon alpha, along with cytoreductive nephrectomy. This was based on some retrospective data from SWOG and URTC as well as a meta-analysis, which showed that there was a survival benefit with cytoreductive nephrectomy. Then came the era of tyrosine kinase inhibitors in 2005, and people started using widely tyrosine kinase inhibitors. So in this new era, they again revised whether there is role for cytoreductive nephrectomy. This was analyzed in these two trials, that is the Carmina trial and the Certain trial. So Carmina trial was a non-inferiority trial where they compared cytoreductive nephrectomy with sunitinib versus sunitinib alone. It was shown that the endpoint was overall survival, and it was shown that giving sunitinib alone was non-inferior, and actually the survival was higher on the sunitinib side. But there was some drawbacks for this trial. One was that based on risk stratification, vast majority of the patients were the poor risk category patients in this Carmina trial. So that was one drawback of this trial. And the second one was the Certain trial. This was a trial which compared the sequence of giving sunitinib, whether you should give cytoreductive nephrectomy first, followed by sunitinib, or the other way around. So it was shown that whichever be the sequence, the progression-free survival at 28 weeks was the same. But if you do a further subset analysis, in those patients who received delayed or a deferred cytoreductive nephrectomy after giving a trial of sunitinib, especially those who were showing a stable disease or there was no progression, in such patients giving cytoreductive nephrectomy followed by sunitinib, it showed a overall survival advantage, but this was a kind of secondary objective of the study. So that was the era of tyrosine kinase inhibitors. Now, over the past 5 years or so, we have changed our gears. Now we are going to immunotherapy, and this is again based on trials like Checkmate 214, 9-year, and also keynote trial 426. So which compared immunotherapy versus sunitinib, and it showed a survival advantage. So now we have come to the era of immunotherapy. So that is the relevance of this type. So we don't have any trials as of now assessing the role of cytoreductive nephrectomy in the era of immunotherapy. So this is a basically a retrospective study. So they taken all patients who were stage 4 metastatic clear cell renal cell carcinoma who received immunotherapy with or without surgery, and the primary endpoint was overall survival. The study had 3 groups. The first group was the immunotherapy alone arm. The second group was immunotherapy followed by cytoreductive nephrectomy, and the third group was immunotherapy for upfront surgery followed by immunotherapy. So the data was collected from the National Cancer Database over a period of around 10 years from 2004 to 2014. So they collected around 6 lakh patients with renal cell carcinoma, of which around 2,900 met the criteria for metastatic renal cell carcinoma who underwent cytoreductive nephrectomy and had received immunotherapy. So in the group 1 arm, which received immunotherapy alone, it was compared with group 2 and group 3, which had undergone cytoreductive nephrectomy. The group 2 underwent immunotherapy first, followed by cytoreductive nephrectomy, and it showed a reduction in mortality of 63% compared to those who received immunotherapy alone, and this was statistically significant. In the second group, where we went for surgery first, followed by immunotherapy, it also showed a reduction in mortality, but it was slightly on the lesser side compared to the group 2, but this was also statistically significant. So that was one thing, that the study showed that there is a statistically significant reduction in mortality when you add cytoreductive nephrectomy along with immunotherapy. Then they also did further analysis. It was shown that blacks tend to have an increase in mortality. Similarly, lower education, uninsured patients, treatment at non-academic centers, lower income, brain mets and liver mets, these are all adverse prognostic factors. So the primary endpoint of the study was overall survival. It was shown that at 2 years, those who received immunotherapy alone had a survival of around 30%, whereas it was much higher, around 70% for immunotherapy followed by cytoreductive nephrectomy, and 55% of those who received surgery first followed by immunotherapy. Similar results were recorded in the 5-year overall survival also, that is around 10% versus 37 and 30%. However, the study has its own limitations. It is a retrospective nature study. There is no validation, and one more thing is that risk stratification was not seen separately. So to conclude, patients receiving cytoreductive nephrectomy, they are having a much better survival regardless of the sequence of immunotherapy. And second is we need to do prospective studies to validate these results. Thanks.
Well explained, Vishnu. Again, actually revisiting site reduction after carbon trial. The two setbacks are they don't do the stress stratification and retrospective analysis. Probably we await a randomized evaluation for what. The two issues are the timing of surgery, whether you should do it upfront or
Yes,
whether you
sir.
should do it. The sunitinib it was used as a litmus, like people
now
giving
it is
a neoadjuvant
considered as a kind of litmus
if
study.
there is a
If
stage
it
of
is responding, then you only do second. Actually, there are 2 more trials which are ongoing. One is the Nordic Sun trial, and one more is the FOP trial by the Southwest Oncology Group. Both are doing ipilimumab with nivolumab 4 cycles. Then those 2 patients who are fit enough to undergo surgery, they are randomized into 2 groups. One group will receive cytoreductive nephrectomy followed by ipilimumab. The other one will receive only ipilimumab. Those who receive cytoreductive, they will have a maintenance ipilimumab. The results are awaited in both the trials.
Yeah, so you want to conclude metastatic RCC, oligometastasis, definitely there is ropocytopenia, and you should treat the
We should, when you go for cytoreductive,
conclude,
it makes sense when you are addressing the metastasis also, either by surgery or radiotherapy.
So metastatic oligometastasis, upfront site reduction
Yes.
with treatment of the metastatic sites. For poor, after stratification, you have a low score. Again, maybe upfront you can do a site reduction. For the bad varieties, whether to start upfront IO or whether you should give sunitinib and check for response and then start. The main impact is you have to know the MDT becomes challenging because it is a morbid surgery, especially in a metastatic patient. It is a morbid surgery. So whether you should do site reduction is still questionable. in a
We need more
poor
studies.
patient. Sir, I want Sridharan sir's opinion also. So that is the selection criteria. Selection criteria.
Yes.
In the certain trial also, the arm which underwent sunitinib followed the patient who had response had an OS method. So, bad histology in a poor patient is never a candidate for therapy because the DFS is OS is 1 year. So if you do a surgery in between, I think. So what about surgery after immunotherapy? Like we have not operated as such after. No, I'm saying what about our experience? We operated. Conclusion, but we'll revisit cytoreduction. Actually, in a clinical situation, it's not a real decision making because we do for poorest histology whether to push in cytoreduction after systemic treatment. The bad sarcomatoid things never, better never put us. The patient really has a poor post-operative.
Yes, sir. Yes. Yeah, a patient who is symptomatic for local symptoms like hematuria, paraneoplastic syndrome, hypertension, you can go for upfront cytoreductive.
That stands today.
Yes, sir, that is it.
What's SBRT? What is it? Okay. But those are small tumors. You're not radiating the whole kidney, right? Okay, thank you.
Thanks.
There is no nothing more. We'll conclude for today and we'll join for next week. Next week agenda will share soon. Thank you everyone for your participation.